Good evening, and thank you for joining us tonight. I'm Kate Lauman, social media consultant for SSM Health. Now tonight, welcome to our first Google Hangout on air of 2015, and we're talking heart health. Joining us are 3 heart experts from across the SSM Health system to educate us on atrial fibrillation, heart valve disease, heart valve surgery, and really just answer any heart-related questions that you may have. Now, during this chat, we would love to hear from you. There are a couple different ways that you can send questions to us. First, we do have an email address set up for tonight's webinar. That email address is askssm@ssmhc.com. You can also tweet us your questions. Our Twitter handle is SSM Health. Use the hashtag AskSSM so we can find your questions easily. Also, you can post any of your questions to our Facebook page, YouTube, or Google+. Just search SSM Health. Well, coming to us first, live from Madison, Wisconsin, is Dr. Jeffrey Kushner, Chief Cardiologist at the Dean and St. Mary's Cardiac Center. Dr. Kushner, thank you so much for being with us tonight.
Well, thank you for having me, Kate.
Tell us a little bit about your specialty.
So my specialty is cardiac electrophysiology, which means that my area of interest and expertise is in heart rhythm disturbances. Here at St. Mary's Hospital in Madison, we have 4 electrophysiologists, several physician's assistants, and nurses who are dedicated to treating disorders of heart rhythm. And we provide services primarily to South Central Wisconsin. Go to the next slide, I think. So, just to briefly explain, the heart has 4 chambers. There are 2 upper chambers called the atrium, 2 lower chambers called the ventricles. And the heart's job is to be a muscular pump of blood. And so what's important from my standpoint is the timing of the beating or contraction of these chambers, which, for want of a better term, is determined by an electrical system. And it's not made up of wires, it's made up of specialized cells which send electrical current through the heart and stimulates the heart muscle to beat or contract. So normally your heartbeat begins in the right upper chamber. It would send out an electrical signal which spreads to both upper chambers. They contract simultaneously, they fill the lower chambers, and then that electrical signal will spread through to the lower chambers of the heart and stimulate them to beat. There are lots of things that can go wrong with that system, and these can result in disorders where the heart beats too fast, and that's called tachycardia, or the heart beats too slow, and that's called bradycardia. And there are a number of options for treating various disorders of tachycardia or bradycardia. So on this side, there are a number of tests that we have available to us to diagnose abnormal heart rhythms, and a number of treatment options depending upon what the rhythm is. Testing can be anything as basic as an electrocardiogram, more prolonged cardiac monitors, and it can extend all the way to doing invasive tests where we insert wires into the heart and stimulate the heart into abnormal heart rhythms, and then treat those rhythms with heat or cold therapy, where we'll damage or destroy abnormal tissue, and that's called catheter ablation. We also implant devices, pacemakers for heart rhythms that are too slow, defibrillators for people who have risks of very serious abnormal heart rhythms, and also we have a lot of medication choices available to us.
All right, great. Thank you very much, Dr. Kushner. We do already have some questions coming in for you, and we'll get to those momentarily. First, though, let's head over to Dr. George Chahoud, invasive cardiologist with the SSM Heart Institute in St. Louis, Missouri. Dr. Chahoud, tell us a little bit about your specialty.
Sure, thanks, Kate. I'm actually a cardiologist with SSM Heart Institute. My specialty is advanced heart failure and heart transplantation, with a special interest on heart valve disease. And we have our structural heart valve program here in St. Louis, where we work in collaboration with surgeons like Dr. David Theodoro, as well as electrophysiologists like Dr. Kushner as well. We have several electrophysiologists in the area. I would like to talk to you a bit about heart valve disease and what does it mean and where we need to go from here. In general, as Dr. Kushner alluded to, there are two sides of the heart, a right and a left side of the heart. Each side has two valves. And we are more interested in the valves that are located on the left side of the heart. For reasons we'll talk about it as we go along this webinar. But in general, those valves are basically a flap of tissues that helps to direct the blood in one direction. So it takes the blood from the upper chambers, for example, down to the pumping chambers. Then those valves will close, and then when the heart squeezes the blood, the other two valves, which are namely the aortic and the pulmonic valve, will open to direct the blood into the major arteries, which basically supplies our system with the blood from the left side with oxygenated blood. So when we have a problem with the heart valve, we got to keep in mind that the valve has two functions. It opens and it closes. So we can have a problem with either of these two functions. So if the valve is not opening properly because it's calcified or restricted, then we end up with a problem called stenosis, or tightening of the valve. On the other side of the problem is if the valve is not closing properly, and as we said, it's supposed to direct the blood in one direction. So if it does not close after directing the blood is going to back up into the previous chamber, and that can lead into problems as well. So what can cause heart valve disease? Well, there are several reasons that can lead to heart valve disease, but most commonly nowadays it's changes related to aging process. It's a wear and tear of those valves, which can happen in any of these valves, which can cause some changes, which either leads to a restriction of those valves because of calcium buildup on the valves, or the valves become quite restricted, and not only that it doesn't open well, but it does not close well and can lead into regurgitation. But there are other reasons which can lead into heart valve problems, and those could be related to congenital problems. Some of us are born with defective valves, namely, for example, a bicuspid aortic valve or a mitral valve prolapse at times, and those valves tends to not carry the load very well and has more prone to develop problems either because of a leak or because of stenosis. But there are other reasons that can lead to heart valve problems, namely either previous heart attacks or coronary artery disease, or possible infections that can seed into the heart valves and can cause destruction of those valves, which can lead into a leak across the valve. And one of the rare causes nowadays is rheumatic fever. We don't see it as often nowadays in our developed countries, but there are a lot of cases that come across the border with rheumatic fever in some of these immigrants when they were kids, and they kind of grow up to develop significant valve problems in their mid-30s or 40s. And the symptoms of heart valve disease are quite wide, and there is a range of these symptoms, but the most common ones are related to patients' inability to carry on their daily activities. They start running out of breath. When they start walking around, they notice that they're not able to keep up with the same level of activities. They may complain of shortness of breath when they're laying down. They may complain of swollen ankles and feet. Also, other symptoms could include feeling tired and fatigued, chest pain or pressure, and dizzy spells, as well as fainting spells, mainly because of stenotic valve, like what happens in severe aortic stenosis. And sometimes it could be a rhythm problem, as Dr. Kushner alluded to. It could be a trigger as an early sign of a valve problem. If the patient goes into a fib, that will be our early sign that maybe there's something else related to that arrhythmia, maybe a structural problem with the heart or the heart valve itself. So how do we diagnose heart valve disease? There are an array of tests that we use in general. Most commonly, we start with a simple plain chest X-ray and an EKG, which can give us an idea whether there are any abnormalities on those. But the central test to evaluation of heart valve disease is simply an echocardiogram. And this is the paramount test because it gives us a clear view of the heart chambers as well as the heart valves. We can clearly see these valves in clear pictures to see whether there is a problem or not. And a lot of times we can use some advanced imaging technologies, including transesophageal echocardiogram, or even 3D technology that will give us a better view, almost a virtual 3D view of those valves that will give us better understanding about what's going on. And a lot of times we do resort to stress testing in patients that were not clear if their symptoms are related to heart valve problems, or we're not clear if they are truly asymptomatic. They claim that they don't have any symptoms, but sometimes we have to prove that the valve problem that they have may be causing problems, but they're not aware of it. And most of the patients, if they need to have any intervention done with their valves, they will need to have a heart catheterization to delineate if there is any blocked arteries, which may need to be fixed at the same time. Always the question comes on what can happen if I have a valve problem. What could it do to my heart or to my overall health? Well, a simple example of that is that we have an example of aortic stenosis, and you can see that there is a critical time, which is the start of symptoms, that in general the outcome could be as good as anybody else without any heart valve problems, but the moment symptoms start, whether it's chest pain, shortness of breath, or passing out, the outcome will go downhill from there, which means that they may end up developing congestive heart failure, coming back to the hospital with recurrent symptoms, and eventually causing significant heart pump problem. So the common question that we get is, when is the best time to operate? We simply say it should not be too late in the process, but at the same time it should not be too early. There's an optimal time of surgery, which is usually at the onset of symptoms in general, but sometimes we have to resort to other qualifiers that we see on the imaging testing to decide whether the patient may need to have a surgery at an earlier time. Because one thing that we have to keep in mind, that there is no medications that can fix a heart valve problem. The only treatment for it in general is surgery, because medications will only improve heart symptoms, but it does not fix the underlying problem.
All right, some great information, Dr. Chahoud. Thank you very much. Last but not least, we have Dr. David Theodoro, cardiothoracic surgeon with the SSM Heart Institute in St. Louis. Dr. Theodoro, thanks for being with us tonight.
Kate, thank you so much for having me.
Tell us a little bit about your specialty and what you hope viewers really take away from tonight's webinar.
Well, my special interest is the surgical treatment of adult cardiac valve abnormalities, as Dr. Chahoud demonstrated, and I work closely. We work closely together here in the St. Louis marketplace within the SSM Heart Institute to appropriately identify and characterize and subsequently treat those patients that have surgical needs at the level of heart valve abnormalities. So whenever I begin my discussion with the patient regarding heart valve problems, I like to have them have a fundamental understanding, and that is the heart has one single sole purpose, and that is to effectively and efficiently pump blood in a forward direction. The right heart pumping blood to the lungs, and the left heart pumping blood to the rest of our body. Underlying that sole purpose of the heart are complex components, the coronary arteries, the sophisticated electrical system that Dr. Kushner described, and as we'll see in the next slide, the four heart valves. The valves that we would like to discuss in greater detail this evening would be the two valves most likely to malfunction in our adult patient population, and that is the aortic valve and the mitral valve, depicted on this diagram. The aortic valve most commonly malfunctions from a tightening process that has been described as aortic stenosis, and the mitral valve most commonly malfunctions by becoming leaky or regurgitant. Next slide. So here we see the normal human valve on the left-hand side of the screen in its closed position, not allowing any blood to move in a backwards fashion. And on the right side, we see the normal human aortic valve open, and it's open freely enough that allows blood in an unobstructed fashion to pass from the pumping chamber to the rest of the body. When the process of aortic stenosis occurs, as is demonstrated on the right side, and that would be compared to the left diagram where the aortic valve is opening freely and allowing blood in an unobstructed fashion to pass through. On the right side of the screen, the artist has depicted this tightening or calcified or stiffening process that we call aortic stenosis, and that provides an obstruction for the blood to pass out of the heart to the rest of the body. Another example of the aortic stenosis problem, in the right side upper portion of the screen, we see the normal aortic valve open and in its closed position, and then immediately below we see the diseased valve from an artist's perspective in the attempted open position. You can certainly see the difference in the open normal valve versus the open disease valve, and then in the closed position similarly. The next slide demonstrates an actual human aortic valve that is advanced in its calcification, and the valve in this particular situation becomes remarkably stiff and loses its pliability, and when it's time for this valve to open, it's prevented from doing that effectively because of the bulky calcium or rock-like formations on the valve. Next. So the surgeon has a number of surgical replacement options at their disposal. This slide demonstrates several of the commercially available tissue valves, be that either tissue of a pig or now more commonly, at least in the aortic valve replacement, the tissue from a cow or calf. Next slide. If a mechanical valve is felt to be the appropriate option, this demonstrates our go-to mechanical valve. The two little black flaps are depicted in their open position. When there are certain pressure changes, these flaps go closed and function as an excellent long-term replacement for the diseased valve. The surgeon can approach the aortic valve in a number of ways. On the left panel is the standard open sternotomy incision. In the middle is a horizontally oriented small, what we call thoracotomy incision. And on the right side, by far and away, our most common and favored way to approach the aortic valve is through a vertically oriented small center incision that we refer to as a mini sternotomy. The next most common valve to malfunction in the adult patient is the mitral valve, and many of us have heard the term mitral valve prolapse. Similar to the aortic valve, the mitral valve is comprised of two major flaps of tissue, but the mitral valve is quite a bit more sophisticated and complicated than the aortic valve in that there are complex structures and connections from these flaps of tissue down to the pumping chamber of the heart, as we can see here. The next slide shows a close-up of that same process. Both the front or anterior and the back or posterior leaflets make up the flaps of tissue, and they are, in again, a very complex and sophisticated way connected by way of these parachute-like cords to the underlying pumping chamber. These four panels demonstrate in panel A, upper left, the normal valve, both the front and back leaflet. The B panel, upper right, demonstrates rupture of these parachute cords. The surgeon, in repairing this valve, would excise or cut out that bad portion of the valve and then close that defect with a suture, as is demonstrated in panel D. And in almost all cases, the opening of the mitral valve will require some degree of reduction or shrinkage, and that's done with this white band that is demonstrated in the D panel. The mitral valve can be approached, again, like the aortic valve in a number of different ways. The most standard would be that of the median sternotomy seen on the left panel. a small horizontal front incision in the middle panel, and again, our favored method of approaching the mitral valve from a minimally invasive perspective is a small incision closer to the right armpit than the front of the incision. Now, the surgeon, through this small incision, can either sit in a standard way at the operating room table next to the patient and use sophisticated handheld instrumentation to approach the mitral valve through this small incision, or as demonstrated in the next slide, we can utilize even more advanced technology, and seen here is the Da Vinci robot system, and we use this actively in our minimally invasive mitral valve practice. This is the portion of the Da Vinci robotic system that actually connects to the patient, and in the final slide we see the complete components of the Da Vinci system. Again, the part that sits next to and connects to the patient in the middle. The surgeon is now removed by 6 or 8 or 10 feet from the patient's bedside and positions him or herself at the video console, and we can control the robotic arms from this surgeon's console, which certainly gives us the advantage of magnification to approximately 10 times that of the normal human eyesight, and we see three-dimensional and in high definition. Kate, thank you very much.
Thank you, and we look forward to hearing more from you, Dr. Theodoro. And to our viewers, as we answer your questions tonight, please keep in mind this is for informational purposes only and is not to be used or relied on for any medical advice, diagnosis, or treatment. If you have questions about your health or any symptoms, please speak with your healthcare provider. We do already have several questions coming in, so let's get started. Our first question comes from Tom in St. Louis. I think this would be best be jointly answered by Dr. Chahoud and Dr. Theodoro. And I know, Dr. Chahoud, you already touched on this in your presentation, but how do you know when it's time for valve surgery?
Thank you, Kate. I think that's a very important question because we always come to a point that we'll have to decide that the patient needs to have an intervention for the valve problem that they have, because not every valve problem will require surgery. We'll have to kind of differentiate what is the best time and when do we recommend surgery. And in general, the conventional wisdom as well as the current guidelines says that there is one of the three reasons to operate on heart valve disease if it's a significant problem. And again, that if we have a patient that has significant valve disease, namely either severe aortic stenosis or severe mitral regurg. The first one is if the patient starts having any symptoms, and that's when I said this is when the clock starts ticking, because the moment we start having symptoms, then we're bound to go down slope from there into further symptoms and further decline in the heart pump function. So we have to capture those patients right when they start having symptoms. But at the same time, a lot of these patients we follow on a regular basis to see when they start having any decline in their heart pump function, and that could be either an increase in the heart size or a drop in the heart pump function in general, because those are also early signs that will direct us at the best timing to operate on the valve. Because as Dr. Theodoro mentioned, the last thing we want is for the heart pump function to go down, because the sole purpose and the sole function of the heart is to pump the blood to our system. So that's what we try to prevent from happening. But nowadays, even in the past 5 or 10 years, we've had some more data coming in that why do we have to wait till the patient start having symptoms or till their heart pump function start going down? We may need to act on this disease process a bit early on. So in certain situations, if we know that there's a significant valve problem, a structural problem with the valve, that we know that it's not going to get any better, and with our current technology we can diagnose that, and with our current surgical expertise like Dr. Theodoro, we know that we can operate and fix those valves either by repair or replacement with a high success rate and low mortality rate. We may opt to do it even before any of these happens: symptoms, low function, or a dilated heart.
That makes sense. Dr. Theodoro, anything that you'd like to add?
Well, I agree with Dr. Chahoud completely, and I think his answer was very, very thorough and excellent. I would say in general, to summarize Dr. Chahoud's points, if we can predict with accuracy, and the community of structural heart valve practitioners like Dr. Chahoud and surgeons who take an interest in this, if we can predict that the underlying valve problem has met criteria from a severity perspective, and that problem has not a chance in the world of getting better on its own, and we can, with acceptable risks, either repair and or replace that valve, we would always, in current times, opt to move at such a time so that we are either preserving or as rapidly as possible restoring heart function. And I think that if there's been significant change, as Dr. Chahoud alluded to over the past 5 to 10 years, it is that willingness to predict that that the heart function is going to go down if the particular valve problem, after it's diagnosed, is left alone, and we can guide that patient to, if you will, a reference center that has expertise in the diagnosis and following and subsequent treatment, then in general the move over this past decade is to intervene earlier.
All right, thank you very much. A question coming in for Dr. Kushner. It comes from someone who was diagnosed with lone AFib about 2 years ago. They say they're on medicine, but only at night. Also potassium, magnesium, supplements, vitamins, and exercising quite a bit. They do, though, still have symptoms every day, but they're able to shake them off. The big impact that's concerning them is coming up on a vacation, if it includes a train trip, aerobic activities, maybe cross-country skiing. Any advice for dealing with the symptoms while traveling, and it may be a little different than your day-to-day activity?
Well, yeah, I think this is an excellent question. It brings up a lot of different points about atrial fibrillation. So, I think first we should define what atrial fibrillation is. Atrial fibrillation is a very disordered activation of the upper chambers of the heart, the atrium. So instead of the normal smooth sequence of activation of the heart muscle, there are thousands of points of light firing in the atrium all at once, causing the heart rate to be very fast and irregular. Atrial fibrillation is the most common heart rhythm disturbance we deal with, and it increases as people age, so that people, as they get in their 70s or 80s, it's a very common abnormal heart rhythm. Lone atrial fibrillation, the term lone atrial fibrillation refers to atrial fibrillation that occurs in an otherwise normal heart. So if you have lone atrial fibrillation, you don't have valvular heart disease, you don't have enlarged heart chambers, you haven't had a heart attack, your heart is otherwise structurally normal. In this particular instance, he describes having symptoms every day. The symptoms of atrial fibrillation can be quite variable, from no symptoms at all to palpitations, heart pounding, shortness of breath, dizziness, chest discomfort. There are a lot of potential different symptoms. He describes the type of therapy that he's on now, which is metoprolol, which is a beta blunts the effects of adrenaline on the heart and slows down the heart rate when it is in atrial fibrillation, but it's not particularly effective at preventing atrial fibrillation. The other things he describes taking, potassium and magnesium supplements, don't really affect atrial fibrillation all that much unless you're significantly deficient in magnesium or potassium, which most people wouldn't be. Exercise is great for your general health, but it's not going to affect atrial fibrillation very much. So I think in this person, there are two avenues of treatment of atrial fibrillation. One is to control the heart rate so that it's not so fast, and for that we employ beta blockers like metoprolol or calcium channel blockers like diltiazem. But the other avenue is to use what are called antiarrhythmic drugs, and these drugs basically affect the way electrical signals form and spread throughout the heart muscle, and they can actually prevent atrial fibrillation. And I think in somebody who is having daily episodes, assuming that his symptoms are daily episodes of atrial fibrillation, I think he probably would benefit from being on an antiarrhythmic drug, which would potentially prevent atrial fibrillation from occurring. And then I think he could travel freely and not have to worry about it.
Okay, thank you very much. Great advice. This question for Dr. Theodoro. Dr. Theodoro, you talked about minimally invasive valve surgery in your presentation. What are those benefits and why are your patients choosing that option, or with the help of you choosing that option?
Well, Kate, another really good question. And in general, if a patient can undergo cardiac surgery and avoid a relatively feared component of that cardiac surgery, and that is having a median sternotomy or the breastplate bone divided in the middle, they would typically choose that option if the other option, namely a small incision over on the side of the chest, can be done in a safe and effective and appropriate fashion. And that's really the guiding principles when I'm speaking with the patient that's seeking minimally invasive surgery. There are certain criteria that we would look for. There are certain disease processes in regards to the valve that have to be taken into consideration relative to the surgeon's approach to that valve. But fundamentally, the patients are seeking that approach as a means of avoiding a sternotomy. And not every patient is a candidate for the limited surgery. By all means, that is the case. And those patients that are candidates certainly do benefit from a more rapid, as a rule, more rapid return to normal physical activities because we've avoided the wound healing process that has to take place. And it usually takes place in a really effective fashion, but nonetheless, and that is the healing of the sternum over a couple to 3 month period of time versus a time frame that's considerably shorter than that when we have the opportunity to avoid a sternotomy. That's from a patient's perspective. From a mitral valve surgeon's perspective, the view that the mitral valve surgeon has through an incision on the right side of the chest is really an excellent view, and in many cases a more superior view of the mitral valve than can be achieved through a center incision. So there's a couple of factors that would lean the team, if you will, and that would certainly be both the patient as well as the operating surgeon and their team, one way or the other.
All right, thank you. This question for Dr. Chahoud, a really interesting question from Laura. Laura says she was diagnosed with mitral prolapse valve in 1997. A couple of years ago, she said she had another ultrasound and she was told she no longer had MPV. Now, she recently asked her primary care physician, and he said that the requirements were actually different back then and today, and she didn't meet the requirement. So she says she's confused. Her heart valve is still leaking, so what do you call that?
Very good question, and that's a source of confusion that a lot of our patients has had, because her primary care physician is right. The previous criteria that we had was more lenient. We used to call a lot of patients have mitral valve prolapse, and in reality it's based on the certain criteria by looking at the echocardiogram. But nowadays we use more stringent criteria that a lot of times that bowing motion of the valve is seen on only some certain views but not in all the views, and we don't label it as mitral valve prolapse because in general when the valve closes it comes into a complete position. When we label it as mitral valve prolapse, what happens with this valve, it starts bowing up when it's closing, and that type of motion is what the mitral valve prolapse is all about. So we have to look at it from different imaging modalities nowadays. We've seen a lot of patients that carries the diagnosis of mitral valve prolapse. In reality, they don't have it. They may still have a leaky mitral valve. That's a totally separate issue, meaning most of people with mitral valve prolapse, they do have leaky valves. But not every leaky mitral valve means it's a mitral valve prolapse. The prolapse is just the motion of that valve when it bows up when it tries to close it. So that's not a disease by itself. It's just the way the morphology of that valve when it closes because of some thickening and infiltration that happens in it. So what I would label her condition at this point in time is that she does have mitral valve disease, and she probably has some degree of a leak across the valve or mitral regurgitation. Beside the point whether she had or did not have mitral valve prolapse, based on her recent echo, she probably does not have it, but she still would require follow-up to make sure that that leak across the mitral valve is not getting any worse as time goes by, because the treatment will be the same whether there is a mitral valve prolapse or not. The fundamental problem is a leak across the valve. The valve is not functioning properly. In mild cases, we may not need to do anything about it except a simple routine follow-up echocardiogram maybe in about 3 to 5 years. But in more advanced cases where there's a moderate leak across the valve, we may need to have a repeat echocardiograms almost annually to make sure that we catch it early on before it starts causing any problems with the heart pump.
All right, thank you very much. Dr. Chahoud, another question for you. You had that slide in your presentation with a lot of different symptoms of those suffering from heart valve disease. We have a couple of viewers kind of wondering what the key number is. Is it one of those symptoms? Is it multiple of those symptoms? When do you have X number of symptoms that you need to speak with a heart doctor? And then what tests do you do to determine what disease they're actually suffering from?
Sure, very interesting question, and in reality, we don't have to have all the symptoms. It depends on which valve pathology or valve problem we have that will dictate what kind of symptoms we have. So any of these symptoms could be an early sign that there may be something going wrong with me. If I'm not able to carry on the same level of activities I used to do before, for example, I had patients tells me, one patient told me actually about a week ago that he used to be able to walk about 4 miles. Now he's still able to walk 2 miles, but this is different for him, and that has progressed over the past 6 months. So this is a change in their functional capacity. That's an early sign that maybe you're not able to perform as good as you were doing before because of a problem with the heart. So that will be enough to trigger a further evaluation. So any of these symptoms would qualify for it, whether it's passing out, dizzy spells, chest pain, or shortness of breath. Shortness of breath is notoriously the most common symptom that most of the patients admit to. And sometimes what they have done is they started adapting to that limitation, and they start reducing their activities because they know now they cannot do the same level of activity. So now I'm walking 2 miles a day, I'm feeling fine. But in reality, that's less than what I used to do before. So to me, that's an early sign that something is going on. We need to see our primary care physicians and see what's going on. And testing-wise, as I alluded in one of the slides, the most important test to find out whether there's a valve problem or not is simply an echocardiogram. That's the first cornerstone test. That will give us a better visualization of all the valves. We can tell for sure if there's a valve problem, where is it located, and what type of valve problems are we dealing with. Is it bad enough that we need to do further evaluation from there? But the first test will be an echocardiogram that will be done and ordered by the primary care physician most of the time.
Great information, thank you. A question for Dr. Kushner. A viewer writes in saying, my heart races sometimes really fast, but just for a few seconds. I haven't told my doctor because there is no pattern and I have no other symptoms. Advice?
Well, yeah, I think, first of all, you should probably mention it to your doctor and have it investigated. It's hard to say what that is. It depends on how, well, first of all, it depends on whether there's any, the seriousness would depend upon whether there's any underlying heart disease. So if you're a relatively healthy person and your heart is normal, those kinds of symptoms usually are relatively benign. But I think the first thing you do to evaluate somebody like this would be to try to determine, first of all, do they have any underlying heart disease? An echocardiogram, again, would be pretty helpful in that regard. It would also be nice to know what the heart rhythm is if at the time it's fast. Now, if it's relatively frequent, meaning it happens on a daily basis or several times a week, we can usually give people an extended monitor where they can record their heart rhythm when they're having their symptoms. and that would give us a lot of information about what it is and whether it needs to be treated. If it's only happening every couple of months or a couple of times a year, we're probably never going to be able to record what it is. So as long as it's not causing too many symptoms and the heart is normal, I wouldn't worry too much about it.
All right, thank you. Now, during this chat, we would love to hear from all of you with questions, and there are a couple different ways that you can send those questions to us. First, you can email those questions to our email address we have set up for tonight. It is askssm@ssmhc.com. You can also tweet us. Our Twitter handle is ssmhealth. You can also post to our Facebook page, YouTube, or Google+. Just search for SSM Health. As we answer your questions tonight, please keep in mind that this is for informational purposes only, not to be used or relied on for medical advice, diagnosis, or treatment. If you have questions about your health, please speak with your healthcare provider. Dr. Kushner, going to go back to you with another question. A viewer writing in, does ablation work for correcting AFib?
Well, the short answer is sometimes. So what is ablation for atrial fibrillation? Ablation tries to eliminate the triggers that cause atrial fibrillation. So there are 4 veins that bring oxygenated blood from the lungs back to the left upper chamber, the left atrium. And in many people, it's electrical activity that originates from within these veins that triggers atrial fibrillation. So ablation means that we do a procedure where we insert a wire into the left upper chamber of the heart and either cauterize or burn around these veins or freeze around these veins to electrically isolate them from the rest of the atrium so that electrical signals that originate in the veins can't reach the atrium and can't trigger atrial fibrillation. So the best candidates for ablation are people who have otherwise structurally normal hearts and who have what's called paroxysmal atrial fibrillation that starts on its own and then ends on its own within 24 to 48 hours. So in that kind of patient, the ranges of success for ablation are somewhere between 70 and 90%, with the higher end success rates being on those people who have normal hearts and paroxysmal atrial fibrillation. But even in those patients, if you go 5 years down the road, the success rates drop to about 65%. So there's no perfect cure for atrial fibrillation with ablation. And in patients who have valvular heart disease, who have mitral stenosis or mitral regurgitation, there tends to be a lot of enlargement of the atrium. And in those cases, ablation doesn't work very well at all. So we're still trying to perfect ablation to make it more effective in more people and more long-lasting. But for some people, it's a good option. It's a very good option, particularly people who aren't responding very well to medication.
A related question with that, a female, age 52, she is 7 months post-PVI ablation, but she is still experiencing arrhythmia like you were discussing. How does she, with her doctor, decide if she should have a second ablation?
So as you say, PVI is what I described as pulmonary vein isolation, where we ablate around these 4 vessels and isolate them from the rest of the atrium. What we do is usually we have a blanking period. We do the ablation. We say for the first 3 months we're not going to be concerned about any atrial fibrillation that the patient has because the procedure itself causes a lot of inflammation and can trigger more bouts of atrial fibrillation. But as that dies down after the first 3 months, atrial fibrillation should go away. If after 3 months you're continuing to have atrial fibrillation, then I think it's reasonable to consider another procedure, particularly if the first procedure led to some decrease in the frequency and duration of your atrial fibrillation. What happens is that although we do this ablation and electrically isolate these veins, they tend to reconnect. The tissue tends to grow back and reconnect. and we just have to go back and usually do some cleanup around the veins to get them completely isolated.
All right, thank you. A couple questions for Dr. Theodoro. A viewer wants to know, how long does a repaired, or in some cases a new valve, last after surgery?
Well, let's start with the first question, Kate, in regards to the repair. And when we refer to mitral or valvular repair, classically we are referring to repair of the mitral valve. The aortic valve is a bit more of a flimsy and less hardy valve from a reparative standpoint, so we'll focus on the mitral valve repair. And a lot depends on the nature of the problem that we were there to repair for. If the problem is relatively isolated to a certain segment of one of the leaflets, most commonly the back or the posterior leaflet, and that abnormality is associated with either a ruptured or an elongated cord like the parachute cord that we saw in the diagram, and that can satisfactorily be excised or taken away surgically, and then the mitral opening can be reduced in size or shrunken, and there's no additional mitral valve type problems, and most importantly, no associated underlying heart pump problems. Those repairs last a very, very long time. With regards to the level of sophistication that we're able to employ now, kind of hard to talk about valve repairs that would last beyond 15 or 20 years because the techniques have been evolving over roughly that period of time. But for those isolated mitral valve leaflet problems in an otherwise relatively normal pump situation, those are highly reliable and durable repairs. To answer your question with regards to replacement, if a replacement of either the mitral or the aortic valve is done with a mechanical valve, picture that we demonstrated, versus a tissue valve, by and large that's a lifelong solution. Not in everybody, but in general, the mechanical or the metal valve, from a structural standpoint, almost, nothing's 100%, but almost never wears out. On the other hand, if we utilize a tissue valve, that tissue most commonly now from a cow as opposed to a pig, in either the mitral or the aortic position, clearly there are durability issues. So with the most sophisticated calf or cow valves placed in the aortic position, we're seeing durability that is approaching, but certainly not exceeding 18 to 20 years, and a little bit less than that in the mitral position. So we've got to pick and choose our valve replacement in regards to either the mitral or the aortic, appropriate as to the longevity, if you will, of an individual patient.
And then what do patients need to do to maintain a healthy lifestyle after undergoing one of those surgeries?
I think, you know, pretty much, Kate, all of the usual suspects from an environmental perspective, and that is a healthy diet, and certainly smoking cessation or quitting smoking, better yet, never starting smoking, maintaining enough physical activity that we sort of avoid the obesity syndrome that is clearly very prevalent in the country today. So that of course is exercise and appropriate diet and managing and monitoring cholesterol levels and the like. So as a rule, it's a somewhat of a long list of environmental issues that we would recommend all of our heart patients, and really all patients in general. First and foremost is the goal to avoid the need of some type of intervention, but certainly maintaining blood pressure and diabetes control, weight, exercise, and diet, and that will go a long way in terms of the heart healthy lifestyle that you've alluded to.
And those questions were from Bennett via email, so thank you for your questions, Bennett. This question for Dr. Chahoud, this question coming from Paul in St. Louis, wanting to know more about what age should men start taking their heart health seriously? I bet I know the answer.
Tricky question. I would say there is no time better than the current time. I would say the earlier you do that, the better. It's never too late to think about it, because at our early ages we think that we are invincible, so we can do whatever we want. But when you think about it, all of these bad habits that we acquire at an early age would come to hunt us down later in life. So I would say now is the time. I would not wait. And this is, as Dr. Theodoro mentioned, it's all basically following a heart-healthy lifestyle, whether it's improving our risk factors, blood pressure, cholesterol, diabetes, or even participating in regular aerobic exercises. And there are some current guidelines and recommendations is at least to maintain a heart-healthy lifestyle, we recommend at least about 30 days of aerobic exercise every day. I would say most days of the week in general.
All right, thank you. A question for Dr. Kushner. This question from a 62-year-old male who's on a minimalist regime, wanting to know if you have had patients with success on a low medication plan. He's had 3 bouts that have all lasted about 20 hours with a pulse between 80 to 180. He's managed to avoid that kind of episode for months, but he is feeling some sort of fluttering or an extra strong heartbeat every day. Should he be doing more than he already is?
Well, I think, first of all, it would be nice to know what the fluttering is. And so it would be, I would either give this person a monitor to monitor his heart for 24 to 48 hours, or give him what's called an event monitor where he could press a button when he has the fluttering. Because we want to know, is that atrial fibrillation or is it just premature beats? Premature beats or skipped beats are very common, and people who have heart rhythm disturbances are very cardiac aware, so they tend to notice them more than most of us would. But if we assume that he's not having atrial fibrillation on a daily basis, that he's just had these 3 episodes, the question then becomes, well, how should we treat those rare episodes that he's having? And I think there are two issues when you come to treat atrial fibrillation, or 2 dangers of atrial fibrillation. One is if you go into atrial fibrillation and you have a rapid heart rate for a long period of time, weeks to months, because that can cause an enlargement or failure of the heart. The heart can begin to fail. But that's not the case here, because all of his episodes have been less than 20 hours. The second worrisome thing about atrial fibrillation is the risk of stroke. And so there is a scoring system that we use to determine whether people who have atrial fibrillation are at risk of stroke. And it involves age, it involves sex, it involves whether people have diabetes or high blood pressure, whether they have vascular disease or other heart disease. So the first thing he'd want to know is, he does need to protect himself from having a stroke from atrial fibrillation. And I don't know what his score would be, but if his score is 0, aspirin alone may be enough. If his score is higher, then there are other blood, we call them blood thinners, but really what they do is retard the rate of coagulation of the blood, or slow the rate of coagulation of the blood. So there are drugs like warfarin, and there are a number of newer drugs that are available that can thin the blood and protect people from stroke. As far as treatment for these types of bouts of atrial fibrillation, if you really want to do a minimalist regimen, there are antiarrhythmic drugs, which I talked about before, that you can take at the onset of atrial fibrillation that potentially, and it's called a pill-in-a-pocket approach. So you get atrial fibrillation, you have rare episodes, and you pop a few pills of these pills, and you hope that it's going to convert you out of atrial fibrillation. And depending on the person, that it's not that never works 100% of the time. It may work anywhere from 50 to 80% of the time. So he might want to try a pill-in-a-pocket approach, and he's also going to want to talk to his doctor about his risk of stroke and how he can protect himself from that.
Yeah, that's interesting. So what is it about it that does increase your risk of stroke with AFib?
So the simplest explanation is that when you're in atrial fibrillation, as Dr. Theodoro said, the heart's function is to pump blood forward. And when you're in atrial fibrillation, blood does not move through the upper chambers, the atrium, at the brisk speed that it's supposed to. And whenever blood sits still, it tends to coagulate or clot, and then those clots can break off and go to the brain and cause strokes. There are probably other factors as well involved in your risk of stroke from atrial fibrillation, some of which we don't understand. But I think the simplest explanation is that blood tends to stagnate in the heart and clot, and then that can lead to a stroke.
Dr. Kushner, is atrial fibrillation curable, or is it something that is treated and hopefully managed?
I think of atrial fibrillation as something that most of the time is controllable. So in most people, we can find a solution through either drugs, ablation, or a combination of drugs and ablation, which will reduce or eliminate their atrial fibrillation. In some people, atrial fibrillation is curable by ablation. But that's, I think, it's not the majority of people. There are people who, as I said before, who are really good candidates for ablation, who have otherwise normal hearts, who have paroxysmal atrial fibrillation, and they seem to do pretty well with ablation. The vast majority of people with atrial fibrillation have other structural heart disease, and for those people, medications might be a better option.
Dr. Theodoro, a question coming in via Twitter. Mike wants to know, what are some of the complications with heart valve surgery? How long would he be out of work, and what's the recovery like?
Well, Kate, I think that that's going to vary on the nature of the surgery and any associated medical problems that a patient carries with them into a valve surgery. But in general, when we operate on the heart, whether it be through a standard front median sternotomy incision where the breastplate bone is divided, or whether we do it through a smaller incision as we've talked about before, fundamentally, when we're at the level of the heart, irrespective of our approach to the heart, we have to do routine heart surgery. And as a rule, that means connecting the patient to an open heart lung machine, as a rule, stopping the patient, and in all cases for valve surgery, actually opening or cutting into the heart to get to the location of that valve, doing our work, and then, of course, repeating the process that I just mentioned. And that in and of itself is the majority of the required hospital stay after valve surgery. And that's usually, I'd say, a minimum of 4 to 5 days, and many times 5 to 7 days. Once we've overcome the need for hospitalization based on the underlying heart surgery, then the profile of the recovery is significantly patient dependent, again, based on body habitus, their level of preoperative activity, and any other major medical problems that they have. When we can approach the valve and spare dividing the breastplate bone and avoid a sternotomy, again, those patients tend to trend towards the resumption of physical activity a bit faster. But the long and the short of it, the hospital stay is roughly the same with both procedures, because you just simply have to get over the cardiac surgery part of it. And then even for minimally invasive surgery, unless you have a desk-type job, most folks are out for the better part of a month. And sometimes it's a little bit longer than that. If you have to have time for that sternal bone to heal and you have a heavy related job, a job with heavy physical activity, well, then we're on the order of a couple of months, 2 months, prior to exposing that healing sternal bone to any undue stress. Now, the complications that you ask about are all the typical complications that would go along with cardiac surgery. Damage to the heart in a number of ways, bleeding post-operatively, and certainly infection, for instance. Now, thankfully, in current times, those complications are very, very rare. Never zero, but certainly very, very uncommon at this particular point in time.
This question for Dr. Chahoud. A lot of talk lately in stories in the media about daily aspirin intake. who should be considering this and talking to their doctor about it?
It's a very good question, and it probably comes from the fact that there are some early studies that show that aspirin use may protect you from having a heart attack or may protect you from having a stroke. And the recommendations at this point in time have changed a little bit, but in general, in men over the age of 45, up to the age of 79, it's still recommended to use a daily aspirin or a baby aspirin to protect from having a heart attack. The data is a bit less robust in women for that matter, but there are some data that show that using aspirin in women over the age of 55 may protect against having a stroke in general. So if we say in general terms, we have to weigh always the risk and the benefit. If we have somebody that has high or multiple risk factors for heart problems, high cholesterol, diabetes, family history, and are male over the age of 45 to 50, I would say there is enough evidence to suggest that using a baby aspirin per day may protect from having a heart attack. In females, as I said, the evidence is not as robust. So if there is no other risk factors in women, I would usually not recommend it unless it's for a protection from having a stroke, a very strong family of a stroke, or somebody that had multiple risk factors, including diabetes. That would be reasonable. In people that had a previous heart attack or had a previous stroke, that's a totally separate issue, because there is more evidence that using aspirin in those cases do prevent from having recurrent events. So if we've had a previous heart attack or a previous stroke, the recommendation is strongly to proceed and use the daily aspirin. But for a general health, it's based on the risk and the benefit in people over the age of 45 for men, over the age of 55 in women, for protection of stroke in women more than heart attacks.
All right, thank you. A question coming in for Dr. Kushner from a male viewer, currently on heart regulators and blood thinners, wants to know if it's okay to fly and to travel when you have AFib.
Sure. There's no reason why you can't. Flying wouldn't have any effect. I wouldn't see any reason to restrict his travel, no.
Okay, great. And his other question...
I guess the one caveat to that would be if you had atrial fibrillation that kind of came and went, and you felt very ill when you went into atrial fibrillation, you probably wouldn't want to travel to somewhere where there's not medical care.
Absolutely.
But flying alone wouldn't have any problem.
He also wants to know, what are the triggers of AFib? Could stress trigger it? What about exercise, caffeine, sodium, and increases in sodium?
So, everybody's different, and in some people, some people we can say, well, yeah, they exercise. All their episodes of atrial fibrillation were induced by exercise, and some people. Alcohol can induce atrial fibrillation. Caffeine, if you take large amounts of caffeine, in some people that could induce atrial fibrillation. In most people, though, for most episodes of atrial fibrillation, there is not an obvious trigger to it. It just happens.
Dr. Chahoud, a viewer's writing in saying they're 50 years old, blood pressure always normal to low, but they do have high cholesterol, also a family history of heart disease and heart attacks. What are the proactive things this person should be discussing with their doctor? What should he have on his mind?
Well, as you mentioned, apparently he does have at least a couple of risk factors, including his family history as well as the high cholesterol. And in general, the recommendation nowadays is at least to try to control any risk factor that you have. So if your cholesterol is high, we definitely need to go by the recommended guidelines, measures to treat that with medications most of the time, I would say. Family history is the only thing that you cannot change. You're born with these genes, you're going to die with these genes. Unfortunately, there's nothing you can do about it. But having a healthy lifestyle is going to be very important. That include regular activities and exercise, aerobic exercise, as I mentioned earlier, about 30 minutes most days of the week. If you smoke, quit smoking. Alcohol should be avoided as much as possible. And then if you do have those multiple risk factors, then again we go back to the recommendation about possibly using an aspirin if he's over the age of 45 with the family history and high cholesterol. It may be advised to take at least a baby aspirin, and then to follow regularly with your primary care physician to make sure that those risk factors are still under control, meaning that your cholesterol tend to change as time goes by and based on your diet and lifestyle modifications. So the cholesterol medication that you're on now that may be controlling at this point in time might need to be adjusted. And that kind of leads us also into the point of the lifestyle changes includes also changing the habits of eating, and the low cholesterol diet will be advised in those situations. And the current recommendation by the American Heart Association is to use less than 300 milligram of cholesterol per day in somebody that did not have any previous heart problems. But they do have multiple risk factors for heart disease.
All right, thank you. And our last question for this evening is a question for Dr. Theodoro, a viewer writing in, talking and wanting to know about what are some of the advancements that you've seen in your career related to heart valve surgery.
I think the level of sophistication from an imaging perspective, namely the cardiac echo, has been a very, very sophisticated advancement. Even in my career, we've seen the advanced and escalating use of something referred to as transesophageal echocardiography, whereby the probe that is actually acquiring the images of the underlying beating heart is placed into the patient's mouth and guided, under sedation of course, down the esophagus and positioned alongside the heart in such a way so as to gain just beautiful views. And that's been taken relatively recently to the level of being able to acquire three-dimensional views of the heart and its chambers and its functioning, and in particular the valve function. And so that technology is certainly an advancement. That technology is available not only in the preoperative period, but we've got that technology available in the operating room. And then of course the enabling technology that has allowed the cardiac surgery community to approach these valves in a lesser or minimally invasive way. Sort of the epitome of that at this particular moment, and of course technology is always changing, would be the utilization of the robot in those patients where the robot is appropriate. So those would kind of encompass the biggest technological advancement. I think there's been an advancement, however, as Dr. Chahoud has alluded to, in general in the philosophy of a level of awareness and desire to treat prior to the onset of heart damage. And I think that philosophically, that's been a very, very important advantage for our patients and their heart preservation from a function standpoint.
Thank you. Such great information. Well, we answered many of your questions tonight, and again, we just want you to keep in mind for informational purposes only and not to be used or relied on for any medical advice, diagnosis, or treatment. Talk to your own physician if you do have questions. Thank you so much to everyone who sent in all those questions, and thank you to, of course, Dr. Kushner, Dr. Chahoud, and Dr. Theodoro for taking the time to talk about a subject that obviously affects us all. And if you're looking for more information on providers in your area, visit our website, ssmhealth.com/live. We will post more information there. Thanks for tuning in, and we'll see you next time.